everyone. I think it's probably a good idea to get going because it's nice to chat at the end. My name's Catherine Dodds. I work at the University of Bristol. I've been working in the HIV sector since before Kevin Fenton's chart started, so it was very interesting to kind of think about the different places that I've been in along that journey, and perhaps many of you did as well. So I work as an academic. I'm a social scientist, brought up in kind of the traditions of sociology and social policy, and I'm also an HIV activist, and I think that for me is a really important part of what brings me into this work. I don't see those as separate boxes. So in terms of our session today, we're talking about insights into PrEP awareness and needs. We've got three tremendous speakers who we're going to welcome, and I will introduce them in turn. We will please save questions and discussions until the end. And for each of the speakers, I will be maybe sitting down there to flag you about time. So I will give you a warning that you've got 5 minutes left and 1 minute left, if that's okay with you. So to start off with, we've got Mike Downey from Renaissance UK, which is based in Blackpool. And Mike is the PrEP project worker there. He's been working there for a year, having been a volunteer before that time at the University of Central Lancashire, studying sexual health. So Mike's presentation forms part of the BePrEPed project, which began in May 2022. So I will leave it with you, Mike.
Hello. You'll have to, if you don't understand anything I say, it's because of the accent. We're just going to put it down to that. Cool. As Catherine said, my name is Mike. I've worked for Renaissance for the past year, and I've been taking over the BePrEPed project from my colleague Patrick, who you might have seen before, I'm not sure. The project ran for 2 years in Lancashire, from May 2022 to May 2024, and for 6 months in Blackburn with Darwin as a pilot project, from October 23 to March 24 just passed. The aim of the project was to increase awareness of and access to PrEP for those in rural and marginalised communities across Lancashire. I don't know if any of you have been to Lancashire, but the villages and cities are few and far between, and a lot of people are in the back end of nowhere. So the point of the project was to try and get the message of PrEP to those people. The original plan was to create a brand that would be visible across the whole county. So we got started on some designs. We first of all had a service user consultation. I won't bore you with the very long and in-depth charts about which colour they preferred, but we ran a service consultation on different colours, different designs, and fonts and things like that, and these ones were the ones that came out on top. However, we did have to be very careful due to the MHRA guidelines on the advertising of medications, also called the Blue Guide. Disease awareness campaigns aren't allowed to advertise specific medications, so we decided to take the pills out because I'm not about to be dragged in front of a judge. So these were the ones that were kind of remade after we made that decision. These were then taken to a designer who professionally made them a bit brighter, made them a bit more, zhuzhy, and we ended up with these, which I think are fabulous. And we wanted those branding messages to be everywhere, so we decided we wanted to put them in GP surgeries, posters, leaflets in different healthcare settings across the county. We wanted to take over the sides of bus stops and have our message driving down every street in Lancashire, and of course to take social media by storm, as is so easy to do these days. But during our planning phase, we costed out just how much it would be, and it would have cost a lot of money. And leaflets get replaced, leaflets get torn, posters get put down, and the next best thing comes up. The next best movie takes over the sides of buses and bus stops, and social media is, of course, a beast that can never be tamed. So yeah, we did cost it up. It would have cost a hell of a lot of money that we just didn't have. So we had to come up with a different plan. We did really like the idea of the bus, though. And we couldn't quite get that idea out of our heads. And then one day, someone put forward the idea of buying our own bus, which, it's a bit crazy, isn't it? But we did. We did actually buy a bus. we bought a bus. We then drove an 8-hour return journey to Scotland to get that bus. We got the inside of the bus completely refurbed. We got the outside of the bus branded and shouted our message as loud as we possibly could. We found somewhere to park the bus, surprisingly more difficult than you'd think, and then wrote the longest risk assessment I have ever seen about that bus. But at the end, it was worth it because we got our lovely Patricia, the little sexy bus. Is she going to pop up? Is that going to work? There we go. This is Patricia. She is my baby. I'm very, very close to her and very affectionate. And she was fully kitted out. She has heating, she's got aircon, running water, electricity, anything you can need. And we took her all over the county, from Burnley to Burscough, from Lancaster to Leyland and everywhere in between. And she could be seen driving down the streets of Lancashire, whether it was rain, sun, or even snow, even though she did take an hour to defrost. But yeah, we really enjoyed taking her all across the county. You could see her at a public sex environment in Lancashire. You could see her at an event, or even just parked in a car park in her capacity as a moving billboard. It's always funny to think we have photos of Patricia sitting below billboards we were originally planning on putting the message on, and then we can just drive her away and don't have to pay them anything, which is lovely. In public sex environments, we were able to use Patricia to provide instant HIV testing to the men who were using those sites, which we found incredibly useful for targeting the heterosexual identifying MSM community. That community, as we know, is incredibly hard to engage in services. So taking the clinic to them with the promise of anonymity and not having to find time out of their schedule to go to a clinic, and it was something that really allowed them to engage with services a lot easier and a lot more discreetly. We also worked very closely with Brooke in Blackburn with Darwin, and we got home testing kits on board Patricia as well. So when we went to the cruising sites in Blackburn with Darwin, we were able to give a full screen to these people for chlamydia, gonorrhea, HIV and syphilis, which was very useful, especially at some of the more popular cruising sites in Lancashire, which are within Blackburn with Darwin's boundaries. Now, on a really good week, I could maybe talk to about 100 people about PrEP. If I had a few events booked in, had really good engagement at those events, 100 people, that's a pretty ballpark average. But in order to get our message out even further, we developed a training program. So instead of talking to 100 people in a week, I could train 12 professionals across that time. And across the project, we trained 228 individuals from over 27 different organisations. And as part of the post-questionnaire survey that we did with them, we asked them how many people they would come into contact with in an average week. The average across all of those people was 34 people. So even if those professionals only talked to a quarter of their clients, that's still 1,938 people. And that we found to be much more impactful, especially because these people were working across organisations all over the health and social care spectrum. We had people working in drug and alcohol work, we had social workers, we had people working for local authorities. And these people are going to interact with people that I never will, that are never going to engage with me. But the message of PrEP can still get to them. The training was incredibly successful, and we've now developed that into an online training course, which is available for free for anyone who wants to take it on the BePrEPed website at beprep.co.uk. We also made a podcast because we thought that the lived experience was something that we were kind of missing from the project. So we developed a podcast where my colleague Patrick spoke to people who are living with HIV, people who work in the HIV sector, as well as those who were members of the original PrEP trials all across the country, including the IMPACT trial. And it was made to increase awareness of HIV and PrEP to the general public by letting those people hear lived experience, and is available on Spotify if anyone wants to have a listen. Now, during the course of the project, we had 3 main challenges. Now, this project focused on PrEP, pretty obvious from the branding and the name and just everything, pretty obvious. But very quickly we realised that you can't talk about PrEP until you talk about HIV, and you can't talk about HIV until you talk about sexual health. So the remit of the project expanded much wider than we thought it was going to at the beginning. Now, that's not an issue for me because, as you can already tell, I love talking. So we got over that one very quickly. And I talked to a hell of a lot of people over the project. But another challenge then pops up because, and nothing can be easy. Because of the nature of the conversations that we had, there was absolutely no follow-up. We never seen these people again. We didn't know if they took our advice and went to a clinic. For most of them, I don't even know their bloody names. And that's information we will never know. That's just the nature of the beast. And kind of the issue of that was, if you don't know how many people are doing something, you can't report your KPIs. And in the charity sector, reporting your KPIs is incredibly important because that's where you get your money from. And we didn't have any KPIs to report. We didn't know how many people attended a clinic. We didn't know how many people took our advice. We don't know how many people literally said, oh, I can't be arsed, and walked away. That's information we'll never know. However, that takes us on to our highlights. Our commissioners were incredibly generous to us. They didn't give us a single KPI. We, of course, reported how many people we talked to and the events that we went to, but they didn't ask us for a single number. They didn't ask us how many people had gone to clinic. They didn't ask us how many people were like, oh, that's great. They didn't ask. And that allowed the project to grow so naturally, to become more than we ever envisioned it would be at the start. For example, we partnered with clinical services in Lancashire to provide full screening and PrEP prescriptions on the back of the bus at Pride events across Lancashire. We've attended 5 of those events with clinical services, and across those 5 events, we have tested 45 people with full screens, venous bloods, everything, hepatitis, all of it. We also prescribed 19 people with PrEP at a Pride event on the back of a bus. And those people, you never know. That PrEP they got that day might have prevented an infection that night. And that's something that we are incredibly proud of. Furthermore as well, the kind of main highlight of this project for me was that we were able to engage with communities that we found it very difficult to engage with before, especially the heterosexual identifying, many of sex with men community, and also the communities that don't access services as much as others. For example, those who are in minority ethnic groups, those who are trans individuals, and this bus created a way for them to engage with services that was more accessible to them. And finally, she did achieve her #1 goal. Patricia did deliver the message of PrEP to the rural communities across Lancashire. And I don't think there's a part of Lancashire that we didn't cover across the 2 years. And I must say, some of the views during our drives were pretty stunning, although she is terrifying to drive. But some of the views were stunning, and that's coming from a city boy, so I think she's converted me. Now, I did say that during the course of the project we found it incredibly difficult to measure impact, but I do want to leave you with some figures. So, in the 2 years prior to the project, Lancashire Sexual Health Services have told us that they had 839 appointments for PrEP. In the 2 years since that project began, they've had 1,561 appointments for PrEP, which is an increase of 86.05%. Within Blackburn with Darwin, they told us that 38 new individuals had started PrEP in the 6 months during the project when it ran in that area. We don't have full figures, but we can estimate from PHE data that that is roughly a 65% increase. And we're still waiting for full figures to compare this to the England average, but in England as a whole, the number of people the increase in PrEP appointments from 2021 to 2022 was 40%. So I think we can safely say that the project did have an impact, and more people are aware of and accessing PrEP because of it. The funding for this project has now ended. It's done. But Renaissance will continue to promote the message of PrEP as a vital part of reaching our 2030 goal, as an incredible tool for people to take control of their own sexual health. We'll simply be doing it under a new name. The name of our new HIV and sexual health service, which is launching later this year to pull all of our commissioned contracts into one. And that name is Revolution. That will be our new HIV service that is launching later this year. More to come on that, and Patricia will be getting some new clothes, so she's very excited, so look out for that. But that is everything from me. I'm happy to answer any questions later on, but thank you.
Beautiful. Love it when a speaker ends just before time, so lovely and very exciting news about Patricia. Next, exciting news about Phil Samba. So Phil is a social activist, a researcher and writer. He's a project coordinator for the Partnership for Black People's Health at the Love Tank. If you've not heard of the Love Tank, where have you been? This is a not-for-profit community interest this not-for-profit community interest community promotes the health and well-being of underserved communities through education, community building, research, events, communication and design. So it's my pleasure to welcome Phil. He's going to be talking about what are the PrEP and sexual health needs of young queer men for 15 minutes.
It's always an issue at conferences. Hi, so what are the PrEP and sexual health needs and experiences of young queer men in London? So I'm going to present on a report that we did from this research paper that was community research that was developed, designed, and written by Dr. Benjamin Weil. I conducted some of the research and alongside Ben and Asad Zafar, who's in the audience. So I want to talk about like kind of what we did, how we did it, and kind of what worked, what came out of it. Okay, starting with rationale. What is data about young queer men suggesting? So indicators suggest that young GBMSM, aged 18 to 25, are a subpopulation with particular needs and experiences of sexual health. 22 data from UK Health Security Agency suggested that young GBMSM have the highest diagnosis of the most common STIs, chlamydia, gonorrhea, and syphilis. Data also suggests that young GBMSM have a different relationship to PrEP compared to older men. Reports from the PrEP impact trial show that young GBMSM were less likely than other men to take PrEP, an observation that has been flagged by researchers and clinicians of particular concern. The uptake of PrEP. The slow uptake of PrEP amongst young GBMSM is possibly because this group has a different relationship with HIV compared to other generations. Many young GBMSM made their sexual debut since the PrEP became available on the NHS and became an established and important tool for HIV prevention as well as U cause U. These advances have made measurable differences to sexual health and HIV with newly or recently sexually active GBMSM coming of age, and the shifting relationships to the HIV epidemic may or not account for some of their sexual health decision making. So there's also a need for a greater understanding of this group's relationship to sexual health and their sexual health services, in particular PrEP provision. Not only is such an understanding integral to better defining the needs of young GBMSM, needs that are only roughly sketched out by numerical data, is a vital way of ensuring that resources and programs of work developed to meet the needs are tailored to the experiences of the people that they intend to serve. So how did we do this? So we did this through focus groups with 18 young GBMSM in October and November of last year. The report came out this February, and it consisted of 13 PrEP users and 5 non-PrEP users, 3 of whom had never used PrEP before. Two of them had used PrEP before but discontinued, and they were ethnically diverse. The majority of them, 10 out of the 18 actually, came from non-white or mixed backgrounds. Eligibility. To be eligible for the study, the men had to be GBMSM, which also included trans men and non-binary people who have sex with GBMSM. They had to be aged between 18 and 25 and living in London. To ensure a broad range of perspectives, the focus groups were conducted with a mix of both PrEP users and non-PrEP users that were people that were not currently taking PrEP but were eligible for it. Engaging non-PrEP users was actually more challenging as there's an underestimation of the barriers that are even in place for them. We suspect that people may not even know our work or even trust sexual health services. We're aware that some of the people that face some of the most difficult barriers might not even have taken part. So through recruitment, the men recruited were through mailing lists known to the Love Tank, broadcasts on Grindr, the hookup app, and social media posts on X, formerly known as Twitter, and Instagram. For the structure, for half of the focus the groups, participants were asked about their experiences and their relationships with sexual health services and information, their relationships to HIV and sexual health overall, and their experiences of PrEP. The second half focused on a related study, which was evaluating and essentially stress testing the acceptability for a potential model of providing PrEP outside of sexual health services. The stress testing has led to a recent online PrEP pilot in East Sussex, and we're now looking into exploring other ways to provide PrEP outside of sexual health clinics. So the findings were broken down into 3 parts: the relationships to HIV and PrEP, barriers to PrEP uptake, and experiences and perceptions of sexual health services. So I'm going to talk about some of them now. Acceptability acceptability of PrEP. All participants considered PrEP a highly acceptable and valued tool for HIV prevention, even non-PrEP users, including people who had never used PrEP at all before, regarding it as something that was favorable and expressed mild concerns about using it. PrEP users were flexible about how they took it, some doing it daily and some doing it event-based. With the PrEP and HIV anxieties, the men that used PrEP universally expressed that taking it helped eliminate their anxieties about getting HIV. They felt that this enabled them to have sex without worrying, to feel more satisfaction, and also allowed them to feel like more carefree, to have more partners and have more spontaneity when it came to sex. These men said that they felt like their diminished HIV anxiety was in part a product of their age. Some of the youngest men in the groups noted that why they felt it was important to understand the history in HIV and AIDS. They spoke of the AIDS crisis as an episode of the past. They were more worried about STIs than HIV. Not all participants felt the same way about acquiring HIV, though. A small number of the men noted that although they used PrEP and consistently considered U equals U, they still felt anxious about the possibility of seroconversion. Explaining their anxieties, these participants cited the knowledge that HIV was a lifelong, although treatable condition, and also shared experiences of growing up in households or cultures where there was a significant taboo or stigma around HIV and homosexuality. Barriers to PrEP. So speaking about the experiences of and relationships to PrEP, PrEP users and non-users described several potential barriers that they may explain for why they or their peers might not be using PrEP. Starting with stigma about PrEP, a number of the men highlighted stigma about the PrEP that might affect people's decision to use it. They noted that among GBMSM there could be a whispered moralizing about PrEP, how PrEP could be considered something that like a promiscuity pill, or it could be something for people that have too much sex or lots of sex. Others noted that PrEP was sometimes regarded as a pill for gay men, and they suggested that this framing could dissuade people from accessing PrEP, especially those who might not be out about their sexuality or be connected with gay men. Access difficulties. Across the focus groups, individuals who had never used PrEP before regarded it favorably and expressed a desire to initiate it. These participants identified a single factor as the foremost barrier to their accessing PrEP. The sexual health services and their infrastructures were excessively complicated to navigate. All of the participants, all of whom were migrants, suggested that these systems were especially difficult to navigate for recent arrivals in the UK, particularly without the support or guidance from someone who's more fluent on how the services work. A non-PrEP user said, "I haven't been to a clinic before. I moved here 2 years ago. It's unnecessarily complicated, and especially for immigrants." Perceptions on the impact of the body. Although PrEP was an acceptable and highly valued by all participants, a few of the men gestured to concerns that they or their peers held or had held about the impact of PrEP on the body. People who had never taken PrEP, for example, all suggested that they had some concerns about the potential for side effects when taking PrEP. Although none suggested these concerns were sufficient enough to stop them from using it, others noted that they had friends who were increasingly suspicious of inorganic interventions such as medications and vaccines. And they feared that PrEP might be an adverse impact on their organs. 2 PrEP users did suggest that they were worried about taking PrEP on a daily basis and how it would affect their health. One said, PrEP user said, "I started taking event-based maybe 3 years ago. And then once I started sleeping with more and more men, people for work, I was then like, no, this makes sense for me to take it every single day. But I was scared about what it could do to my liver." going into the experiences and the perceptions of sexual health, sexual services. There was coming under the confidence of sexual health services, participants expressed confidence in the utility of services provided by clinics, noting especially that they tended to trust clinic staff to instruct them on which vaccines to take. Many of the men noted that clinics were key to their early education about STI and HIV prevention methods. However, they also explained that they only received this information upon their first visit to a clinic as a young person. Typically following a sexual encounter that left them anxious about exposure to HIV, they noted in this way that clinics were an ad hoc replacement for early and inclusive sex ed. They also praised clinics that they deemed queer-friendly. Participants tended to value non-judgmental encounters with practitioners and, where possible, forming welcome and friendly relationships with the staff of the clinics that they frequented. Service access issues and impact. The men described difficulties accessing appointments at clinics. They complained about the scarcity of appointments, whether for PrEP, STI treatment, or testing at the chosen clinic. Available appointments were often at times that were impossible to attend, for example, like during the day. And for walk-in clinics with no options of advanced booking, participants complained about the excessively long waiting times, which made it impossible for them to attend. And several of the men shared a similar experience of queuing for appointments in the early morning, only to be turned away. Some individuals felt that these failures of service access had worsened since COVID had started, noting there hadn't been a reversion of cumbersome systems adopted in response to the pandemic. A PrEP user said this: "In London especially, it's like gold dust trying to get these appointments." Gaming the system. Some participants shared methods of gaming the system in order to get an appointment by saying that they had an STI when they didn't, or by searching for appointments across several different London clinics, with one of them saying that he had to look across 4 or 5 different clinics before he could even make a booking. Participants noted that moving clinics routinely made keeping track of, on top of vaccine protocols, difficult because necessary records were not shared between clinics. The men reported that young people, especially those moving into London, not just making their sexual debut, may find navigating sexual health services for the first time particularly confusing. Views on online testing. For many participants, online Sexual Health London self-testing kits were a much valued alternative to clinical appointments. Some of the men described a pattern of alternating between receiving tests in the clinic, being tested in the clinic, and testing at home. But not everyone valued online testing. In addition to the loss of what they valued about clinics, some participants commented that they found self-testing difficult and even unpleasant to do, particularly when it came to drawing blood. Lastly, negative experiences of clinic care and organization. A handful of the participants described having a significant negative experiences in clinics that impacted them in various ways. One participant had an encounter with a doctor who he felt was judgmental about his sexual behavior. He described because of his experience, he considered not returning to the clinic at all. However, he was convinced to try again by the quality of care he received from another member of staff. So, discussion. The findings from the focus groups aid in developing and understanding the young GBMSN's relationship to sexual health. They may also be instructive for continued efforts to improve the delivery of sexual health services, accessing them. They're broken into 3 parts. PrEP promotion and access, tailoring work for young people specifically, and sexual health beyond clinics. I'm not going to get into all of what we can do, but I do have copies of the report, so if you want to know, you come to find me after. Lastly, I just wanted to close by saying this. Although HIV mirrors the inequalities in the world, this is about equity and not equality. It might take longer, it might be more work, and it might be more difficult to improve the sexual health of young queer men. But just because it's more difficult doesn't mean we shouldn't do it. Thank you.
Brilliant. Thank you very much. Again, smack on time. Love it. So that just leads us on now to present our final speaker with this fantastic panel. So I'd like to introduce Renee West, who is the Development Manager for the GMI Partnership and Positive East. So she's held this post for the last 6 years. Renee holds a doctorate in public health from LSHTM, London School of Hygiene and Tropical Medicine, and a master's in health policy and financing from the London School of Economics. So Dr. West has worked in public health for over 20 years with organisations and institutions in the UK, in the Caribbean, Europe, the US, and includes UNAIDS, the Pan-American Health Organization, and the Pan-Caribbean Partnership Against HIV and AIDS, as well as LSHTM. During this time, Renee has dedicated over, oh, that's me beeping, thank you. That was when you were going to finish. During this time, Renee's dedicated over 16 years to HIV research, programming, and planning. Her HIV research specializes in using qualitative approaches through community, participatory, gender, and equity lenses. She also has interest in the impact of how anthropogenic changes in climate impact on health, and actually this might be a conversation where some of these things need to start intersecting, as Kevin was saying earlier, thinking about things in new ways. So please welcome Renee.
Thank you, everyone. How do I beat those two brilliant presentations earlier? Okay, so good day. I declare that I have no conflicts of interest. And just in case you did not know, the GMI Partnership is a collaboration of 3 London-based HIV prevention and support charities: Metro Charity, Positive East, and Spectra CIC. They provide pan-London community-based sexual health services to diverse communities across London, including, but not limited to, the LGBT+ and Black, Asian, and other racially minoritized groups. As background, in 2018, a London-based PrEP champion project demonstrated gaps in PrEP knowledge and usage among key groups with a significant HIV risk. This present study, conducted by the GMI Partnership, follows up with in-depth focus group. Its objective is to explore PrEP awareness, access, and adherence among people from Black, African, and Caribbean, Latin, gay, bisexual, and men who have sex with other men, and trans and non-binary communities. I'm not going to go through all the demographics, except to say that across the different communities, most common genders and sexualities were represented, and we had a wide age range of participants. The actual number of participants were limited, so there can be no direct generalization to the entire London population of the different communities, but that was not the objective of the study. As an opening question, and to better understand participants' attitudes towards PrEP and provide some context, the participants were asked, do you think that PrEP would be good for you? If so, why? Overwhelmingly, and to be expected, the answer was yes. Using PrEP as a means to preventing HIV was a consistent belief among all 3 communities, albeit with a different understanding, a slightly different understanding among the different populations. Within the BAC community, participants thought that PrEP would provide an additional level of protection, for example, in case the condom bursts or their partner forgot to take their ARTs. Within the Latin GBMSM participants, it was believed that the use of PrEP encouraged more regular HIV testing. And with the trans communities, participants thought that the greater PrEP awareness would encourage more discussions around HIV prevention. Similarly, the theme relating to empowerment and mental health impacts had different interpretations within the different populations. For the Black, African, and Caribbean participants, this related to taking back control of their lives and the mental health impact of receiving a positive diagnosis. For the Latin GBMSM participants, this meant empowering individuals by giving them control over their sexual health and reducing anxiety in sexual encounters. For the trans communities, empowerment, and mental health impacts meant that PrEP awareness will lead to more appropriate HIV prevention services. Physical health impacts by participants in the Black African Caribbean community were related to progression to AIDS and how PrEP might prevent that, whereas physical health impacts by participants in the Latin GBMSM community were related to encouragement that PrEP would allow for HIV prevention and treatment as well as other diseases. Participants from the Black African and Caribbean community also viewed PrEP from a public health point of view. The more widely PrEP is used, the slower the transmission of the virus through the population. Some individuals, particularly sex workers of the Latin GBMS cohort, experience financial benefits from PrEP use. So what were some of the avenues for information dissemination and access and receipt of PrEP among the different communities? With regard to information dissemination, all participants stressed the need for greater awareness. Trans participants spoke about there not being any visibility to see other people like themselves who might already be taking PrEP. If you can't see it, you can't be it. And the desire for more queer-friendly spaces where they could discuss and disseminate PrEP information for themselves. The use of digital and online technology for increasing awareness was also deliberated. For example, using QR codes on posters to help direct people to more information, as well as how to access PrEP. BSc participants also spoke about healthcare providers engaging in more discussions with BSc women. For access and receipt of PrEP, participants discussed the use of pharmacies and ordering online with discreet packaging for home delivery. BSc participants also discussed the use of vending machines or a model similar to the Amazon pickup and drop-off service once all the health checks were done. Access and receipt from healthcare providers within the BSc community received mixed reviews. Older BSc participants indicated that they would prefer to access PrEP from their GPs rather than a sexual health clinic due to the HIV societal stigma associated with the sexual health clinics, whereas the younger BScs said they would use online services first. This can be partially explained since many of the younger participants were not registered with a GP. Latin participants preferred to use sexual health clinics because they could also have their tests done there. Medical transphobia was discussed as a barrier to access and receipt of PrEP by some of the trans participants, and thus the preference was for a community setting or online ordering. For both information dissemination and access and receipt, participants from all three populations suggested a community outreach model, such as the use of a sexual mobile health clinic. Thanks, Mike. These lived experiences produce a rich spectrum of insights about the potential barriers and facilitators to PrEP adherence. Some of the barriers discussed among the BSc and Latin GBMSM participants included side effects of PrEP. The Latin participants were also concerned about drug interactions with other medications such as antidepressants. Other barriers were lifestyle and everyday habits, such as just being able to remember to take one's tablet. Also work disturbances and interruptions, such as in the case of sex workers, when they go to a client's house, they can spend up to 24 hours and lose track of time. Among the trans community participants, additional barriers for PrEP uptake and subsequent adherence were concerns about the potential for PrEP shortages, historical marketing of PrEP to only GBMSM, and the belief that there was a cost attached to accessing PrEP. This belief that there is a cost demonstrates the lack of awareness, uptake and use among the trans community. Facilitators discussed and suggestions made by participants to overcome barriers to PrEP adherence included the use of pill boxes, alarms, and getting into a routine where, for instance, you would take your PrEP tablet as soon as you had breakfast. PrEP injectables were also discussed among all communities and were found to be particularly favorable among the BSc and Latin communities. So, my take-home points. We need to increase PrEP awareness and expand access and receipt venues. Like Mike, we also have a bus. This was also mentioned in Phil's presentation. But barriers to PrEP adherence include side effects, potential drug interactions, and busy lifestyles, some similar to the queer participants in Phil's study. The importance of tailored community outreach models informed by lived experience in achieving and overcoming the previous points cannot be overstated. My call to action to you. As we have heard, all three populations suggested community outreach models, including a mobile clinic and trans-friendly places for information dissemination and access and receipt of PrEP. The 2024 roadmap for meeting the PrEP needs of those at significant risk to HIV has stressed the need to reduce inequalities in PrEP access, uptake, and use among the global majority and other key populations with a significant HIV risk, including those in this study. PrEP is currently provided by specialist sexual health services. However, there is room for improvement in other settings, as acknowledged by the roadmap. Community organizations like Metro, Positive East, and Spectra have already played a major part in increasing knowledge and awareness and changing attitudes towards uptake and use among key groups. In particular, BAC heterosexual men and women, other racially minoritized GBMSM, as well as trans and non-binary populations. The roadmap is cognizant of the important role that the broader HIV voluntary and community sector play in ensuring equitable and effective PrEP use. And as this study has demonstrated, the key groups want us to play a role in achieving this. In the words of Winnie Byanyima, UN AIDS Director, communities are not in the way. They light the way to the end of AIDS. Let communities lead. I would like to acknowledge the other researchers and authors without whom this enlightening piece of work would not have been possible. Marcia Hoyt, Vix Thompson, Leonardo Pavam, the GMI Partnership Community Workers, Dee Wanks from Spectra CIC, Emma Jones and Anders Nielsen from Metro Charity. I would also like to thank City Bridge Foundation for its support. And finally, I would like to thank the participants who gave of their time and insight. Thank you very much.
Wow, thank you very much. And Renee, I particularly appreciate you kind of drawing the threads through, right? Because actually we're hearing a lot of themes coming up that have similarity and some difference, but quite a lot of things that are sitting together. And I just think that there's so much for us to reflect on. So I'm going to start with a question that I don't want you to answer immediately, but for you to maybe answer at the end. And all of you can too. So given that the theme of the conference is equity and impact, I'd like you to think what you think the primary structural cause, and you have to pick just one, might be that's most responsible for all of these inequities in relation to PrEP access that everyone has been focusing on in terms of your interventions and your research. Once you think about that priority structural cause, then what is your priority demand for addressing that structural issue, and who is that demand to be focused upon? For instance, who is the policymaker? Who is the decision maker who needs to own responsibility for that demand? Okay, so that's for you to ponder and for you to ponder as you also think about your own questions. And we have someone who's got I'm going to carry around a microphone, but this one doesn't work. That's fun.
This one does.
Yeah, but then you don't have a mic. Yes, it does. So thank you so much. So reflecting on some of the questions that you'd like to bring to our speakers, who has something on their mind? Okay, I see a hand there, the person in the blue shirt. And if you're comfortable to say where you've come from, what brings you to the conference, that would be grand.
Yeah, I'm Debbie Flanagan from Gilead Sciences, and we're a sponsor today. Can I just say, first of all, thank you very much to the three of you for your presentations and for the work that you are doing in this prevention space. One of the questions I've got is for Renee, actually, and it's your BAC population that you've interviewed. I'm here, Renee. I'm behind, hiding behind the podium. So it was the BAC population because you've got your Latin GBMSM. What proportion of your BAC population were heterosexual women compared to men as well, and your GBMSM?
Okay, so I really can't remember everything, but the BSc, you asked about the sexuality, basically.
Yeah.
Okay.
So your sexuality and how many were GBMSM compared to heterosexual as well?
Actually, it was kind of like split right down. So we had about 7 straight BSCs, and we had about 7 GBMSM.
And women?
Women, we had 8 cis females and 6 cis men.
Fabulous. Thank you very much.
Okay, you're welcome.
Brilliant, thank you very much. Thank you. More questions and thoughts? Yes, please.
I can probably speak loud.
We're recording, so we do need the...
It's just a question for Phil, actually. So I'm Steve. I work up in Norfolk with the NHS sexual health provider, and I just heard you make reference to Grindr, and we try and do some sexual health outreach on Grindr. And I was really just trying to find out whether you did it under the auspices of what you were, or whether you just had a sort of a fairly anonymous profile so that they didn't really know what you were doing on there.
So we have used NetReach on Grindr before, but there's been times where the accounts have been removed and stuff like that.
Okay.
We've spoken with Grindr sometimes because if we say this is our account and this is the phone that we're using, they can sometimes allow you to do that because it works in their benefit. But the way we did it was through, like as soon as you open up Grindr, it has that pop-up message about something. We did it through those. We did it through broadcasts as opposed to like contacting people. So,
okay, that's cool.
Yeah.
Great, thanks.
You're welcome.
In the middle, in the white shirt here.
Hi, my name's Johnny from Positive Health Lincolnshire. My question's for Mike. We do a similar thing of going to like on-site, like PSC sites and things, and doing testing. But we've tend to found we rent a camper van, like just an anonymous camper van, and take it testing because having like branding and things, a lot of MSMs don't like that. Have you found any that people don't want to come and talk to you because you've got a branded van or anything like that?
Sometimes it's half the people there like the fact it's branded and like that they can see it, and the other half are like, why are you here? And honestly, it just depends on the day. We usually broadcast it on like Squirt and Grindr and other platforms like that when we are going to be there, and be like, we'll be here for like an hour and a half, then we'll get out your way. We're just here in case anyone needs it, and then we leave. Some people are kind of like, why are you here? Like, you're drawing attention to this. This is against the whole point of this place. And then the other half are like, oh, it's really great that you're here. Depends on the day. But we have experienced it both ways, really.
How do you get around the people that don't want to come and talk to you if there is branded? Is there a way, or is it kind of like they're not going to talk to you either way? So
yeah, it's basically like they're not going to talk to you no matter what. We do a lot of outreach that's not on the bus, it's just in our cars. So we kind of try and cater to both. The main PSC area that we go to is quite big, so you can kind of hide away in a corner somewhere, and you can kind of stay away from the main area of it and be like, we're just over here if anyone needs us. Yeah. But yeah, to be honest, we've seen more positive than we've seen negative. And when the negative does happen, you kind of just have to go with it.
I think it's also fair to say, actually, you're training those other people in other sectors is also how you're going to reach the people who are never going to come up to a branded van. So I think that's, I think it's fair to say that's also an important part of it.
Well, hopefully that was the point of the training. So fingers crossed it worked.
Or Patricia could have like a dress on one side and nothing on the other side, you know. So she could kind of be, you could park her one way or the other and see. Actually, that would be a really interesting test in terms of seeing if people will walk up to the white side of the van rather than the branded side of the van. But that's just me being weird. Okay. Yes, over here. Good exercise for our volunteers. And keep thinking about those questions that I asked because they're coming back for you.
Hi, everyone. My name is Stephanie. I work for the Caribbean and African Health Network. My question is to both of you, because as Caribbean and African Health Network, we work a lot in the community, and most of the community engagements, we invite people like you to come with your bus and do some testing. And I met with someone from the African Advocacy Foundation, which I usually invite to some of our events. So the problem is, it's around stigma, language, and sometimes we work with asylum seekers and maybe refugees, and some of them, English is not their first language. So my question is, do you have people who can interact, example, Somalians who can speak English? Do you have people who can interpret to them? And some of them, as asylum seekers or refugees, they're not registered with the GP. For example, if they need PrEP, how can you help them? And again, another question is to both of you again. I know about PrEP, but I don't know if we're going to touch on post-exposure prophylaxis, because some people already have encounter with someone who didn't prepare for, and in order for them to be safe, how can they get that help? Maybe emergency help or something. So have you have provision for something like that?
So is that for all of us?
Yes.
Okay. Sorry, I wasn't sure. Does anyone want to take it?
Hi, thank you very much for that question. Very good question. As far as, yes, language barriers, there is an issue not only with the Black African, but for a lot of the communities and the asylum seekers and refugees in London. There is an issue about language. With some things, yes, we do have interpreters, translators at the actual site. We also have documents and other PrEP documents translated already. The other question that you asked about was about getting, I'm sorry. PEP. We will talk to you about PEP if there are issues. We don't actually give out. We will try and signpost you as to where to get PEP and or PrEP. That was it? Okay. Thank you.
Up in Lancashire, obviously it's different. Within Lancashire, you don't need to be registered with the GP to get PrEP. So they can go to sexual health services, and that's completely separate. So even the ones that aren't registered with the GP can still access PrEP. In terms of PEP, we have very clear pathways that we've made with clinical services as to where people can go to access PEP if it's needed. And then along the testing for people in asylum seeker communities and things like that, quite a lot of asylum seekers in Lancashire are in hotels, are still in hotels, and we do testing at the hotels and signpost to different services as well. The clinics that we work with do have translators that they can contact if that's needed, and the hotels themselves also have translators. And same as Renee, we have our literature translated into different languages, and then we also make use of our websites as well. Our websites can be translated live through Google, so that has become an increasingly useful tool.
At the Love Tank, across all of our websites, a lot of our information is available in like different languages. We have like, I think it's 7 is the typical number that we do. But I think the issue that we have is that in clinical settings, people that speak different languages don't know that they can ask for interpreters. So I think that's where the issue lies in that. A solution off the top of my head would be to book with someone that might know the system or something along those lines. And as for PrEP, there's been a huge shift, I think, since PrEP has become more available, in the sense of, like, conversations about PrEP are just not had as much. I think it's a lot more difficult to access, but it's also partially due to how successful we've been in this country with some of the advancements with HIV.
Yeah, thank you very much. Okay, so then heading back to that original question that I asked, and we're on the road to wrapping up the session. Think about sort of the one big one for you in terms of structural causes of these inequalities that we're looking at, and whose door do you want that to land at, Renee?
Okay, I may be getting in trouble on wading
Go
in
for
waters
it.
that I should
It's
not
like
be.
you're being recorded or anything.
But I think, as far as structural inequalities, I think the health system has a big part to play in this. For example, and I think Professor Fenton coming on with the second HIV action plan is great, and I'm sure he's going to keep his promise on that, but I'm going to make sure that he's behind that, as well as the minister. And also the PrEP guidelines, and I know they're being updated to allow access to everyone. For instance, as I mentioned earlier, PrEP was targeted mainly to GBMSM. The guidelines basically, they say that everyone can get it, but in practice, that is not so. Yeah. And I speak particularly for women, right? We have had cases where we have taken a woman who's obviously in need of PrEP and who could benefit from PrEP. We would take them, we would walk with them to their appointment. They would be refused, or they would be asked to come back so many different times.
Okay, so what's your ask?
My ask is that these new guidelines are very, very specific, and that that everyone can access them.
Brilliant. Okay. Phil?
Thank you.
I think mine is structural racism.
Yeah.
I think structural racism has such an impact on healthcare across so many different parts, HIV including that. I think my ask is to everyone. My ask is to governmental bodies, the NHS, everyone in this room, everyone at this conference. I think a lot of the time we acknowledge that racism is an issue within HIV prevention, but then not much comes from that. So, yeah.
Okay, thank you. Mike?
Mine, Lancashire's a big place, and there are only 5 clinics in the whole county that offer PrEP. PrEP needs to be available in more places, in more venues. It needs to be available to those who don't live in a city centre, and it needs to be available in more settings, not just clinical.
Yeah.
And I think my ask is to the guidelines, to BASH. Those guidelines need to be more encouraging and more...
Okay, BASH won't make that clinical access happen. So the ask is to whom?
I think the ask is to the ICBs, the Integrated Care Boards, to say you need to look at this as a real issue, that people are... I talk to people from villages in Lancashire that are saying, I don't have a way to travel to that place. I can't do this. When there is a sexual health clinic right down the road from them, it just can't offer PrEP. And I think that's probably my biggest one.
Brilliant. Okay, we are stopping there, but thank you so much. And please thank our speakers once again for a really great session.